Just a reminder that we are recording the meeting tonight, so as you just heard. So good evening, everyone. It's very nice to see so many people registered with us tonight. On behalf of Healthwatch Camden, I would like to welcome you all to this event on long COVID or post-COVID syndrome. I'm the chair of Healthwatch Camden, and I'll be our chair for this evening. It's wonderful to have so many participants. We have around 80 people registered to join us tonight, which is why we had to wait for the whole thing to load up and everyone to be admitted. So thank you. Because we are a large number, I want to go over a few housekeeping rules, which will help us to make sure that the meeting runs smoothly. We ask that everyone except for the speakers stay on mute. I think we're all used to that now at all times. You'll find that you're automatically muted, actually. Apologies for this. We also ask that everyone except the presenters turn off your video so that helps the reception for everybody. It helps everyone's online connection, means we can all find and see the speakers and interpreters easily. We have got the chat function open this evening, and there's a message there explaining how that's going to work. So although we're not able to take live questions as such, you're welcome to put something, any comments or any questions you have in the chat box. We will keep an eye on that during the evening, and if there's time, we might ask some of the questions, or if anything really important comes up, we will ask that, try and find time to fit in those questions at the end. As I said, the meeting is being recorded, so you can listen again if you miss anything. The recording will be sent to you automatically after the meeting and will be used in the public domain. We'll provide a full transcript on our website. We know now the recording has started. I would like now to introduce you to our two British Sign Language interpreters, Louise and Tamsin. So if you want to say hi, Tamsin's with us at the moment. Louise, I think, is got her camera switched off just now. Louise and Tamsin will be swapping in and out every 15 minutes or so, and you should be able to pin them. I'm sorry, I don't fully understand how that works, but I think there's some information in the chat box. And because there are two interpreters who'll be swapping in and out, it's a good idea to try and pin both. Oh, hi, Louise, I see your picture now. Do you want to just say hi? I hope that's sufficiently clear for people. For non-BSL users, we recommend you view the event in speaker view. There's also a speech-to-text interpreter here, Norma, and her advice is if you are someone who's going to use this function, if you could click CC at the bottom for embedded captions. And also there's a link to full stream text captions in the chat box. So hopefully if you are regular users, you won't find those instructions difficult to understand. You can follow us on Twitter at HealthWatchCam for live tweets throughout the meeting. And you're very welcome to tweet about the event if you wish, using the tag at HealthWatchCam, and using that as the handle, and then the hashtag Ask About Long COVID. This is a question and answer session, and thank you very much to all of you who've sent us in your questions. We have received many, and of course we cannot get to them all, but I'm going to ask 26 questions based on those that you have all sent in, and I hope we'll manage to cover most of the issues that you have raised. We will also be sharing the full list of all our questions with the members of the panel, so all the members of the panel have seen all the questions in advance. The goal of this event is to provide you with factual information on this novel condition, long COVID, and how to get support across North Central London. Finally, for those of you who haven't already met our new director at Healthwatch, I'd like to do a brief introduction to our new director, Stephen Hurd. So Stephen, if you want to put your video on and say hi. Stephen there. Anything you want to say?
Good evening, everybody. Yeah, just thanks for joining us. We hope that it's a really useful session for all, and we appreciate your time this evening and look forward to some of the questions being answered and interaction from you all. So I'll keep it short and brief and let Louise continue, but nice to meet you all.
Thank you. So before I introduce our speakers, we just want to do this little warm-up exercise, which is a question of a poll, which will be shared with you in a minute. We'd like you to answer this question on what brought you here today. And we're going to share the screen in a moment, I hope. This will be an anonymous poll. Is it happening? Can't see it. Oh, there we are. So the question is, if you, what brought you to this Q&A event on long COVID-19? So if you could just make a choice, that would be really useful. So everyone's saying, I have long COVID and want to learn more. So that's 100%. So excellent. And there's a second question. Are we just doing the one question? Or are we
just
doing
the one for now.
Just the one question for now. Okay. Thank you very much. Okay, let's move on then to our speakers. So this evening, we're very pleased to have with us a very knowledgeable group of experts who really should be able to help unpick some of the questions that you have. So I'd like to introduce each person, and they have an opportunity to just say a couple of words about themselves so you know who they are. So we'll go first to Dr. Melissa Heitmann, who's long COVID clinical lead at UCLH. Melissa.
Thanks. Yeah, I'm Melissa Heitmann. I'm a respiratory consultant by background, but now a post-COVID clinician. And we've been seeing patients with long COVID since May 2020 at UCLH. We've had 3,000 people through the clinic. And since September, I've been acting as a national specialty advisor with the NHS England long COVID programme team, which has really been very useful in giving me a sort of broader vision of everything that's going on in the space. So thank you for having me.
Thank you very much. Secondly, we have Dan Windross, who's Assistant Director of Integration at North Central London Clinical Commissioning Group. Dan, are you ready to say something? You're on mute, I'm afraid.
There we go. Sorry, still getting used to Zoom. My name's Dan Windross. I work for the North Central London NHS Clinical Commissioning Group. Just to say a quick word about what CCGs, clinical commissioning groups, do. It's the organisation of the NHS that's responsible for helping to plan and fund and coordinate services across the NHS. And I've been working from a commissioner side to develop the pathway and services for long COVID in our patch of the world. So thank you for inviting me tonight.
Thank you very much. We also have with us Heidi Ridsdale, who's physiotherapist at Central North West London Long-Term Conditions team. Heidi.
Hi everybody. Thank you for having me here this evening. So I am co-clinical lead of the newly developed Camden COVID recovery service. I am, as Louise said, a physiotherapist, a respiratory physiotherapist by background, and I've been seeing people recovering with long COVID in the community, and also been working with Mel Heitmann in the UCLH clinic at UCLH.
Thank you. Then we have Dr. Wikum Jayatunga, who's public health consultant, Camden and Islington Public Health. Wikum.
Hi everyone. So I'm a consultant in public health, and I work in Camden and Islington Public Health team. And we've been supporting colleagues in the NHS, such as Mel and Dan on the panel, with the data on long COVID to understand the impact it's having locally across North Central London.
Thank you. We will be joined a little later by Kirsten Waters, who's Director of Public Health for the London Borough of Camden. She's a little delayed. She's had to go to an emergency meeting this evening. So, but she will join us after a bit. And lastly, we have Dr. Stuart Mackay-Thomas, who's GP partner at Hampstead Group Practice. Stuart.
Hi, thanks everyone for inviting me. Yeah, I'm, as you say, Louise, thank you. I'm GP at Hampstead Group Practice, but my role here is to help support the newly founded multidisciplinary working that helps manage our patients with long COVID in the community. As you can imagine, people with long COVID often have multiple needs, and it takes a number of disciplines to help manage them and sometimes their carers. So my role since the summer this year has really been helping to discuss patients and kind of bring together everyone's thoughts and a discussion about how we can help patients. And it includes the multidisciplinary team, mental health, UCLH, CNWL, and then also drawing on all the GP records, which have a rich set of data and information about things like the kind of work and their medical problems and so on. So my role is fairly new, but I'm also helping support clinical leads, newly established clinical leads across the other boroughs in North Central London. So thank you for having me.
Thanks very much. And I think probably the poll didn't work very well. I think I probably misinterpreted the results, because I've seen a few comments in the chat box saying it's not 100%, I didn't have long COVID, and I apologise to the group for getting that wrong. I think something went wrong, and the team will have a look at that, and we won't misinterpret the results in future, and apologise. So it did seem odd that everyone should have suffered, and I think I probably didn't leave it long enough, perhaps. I don't know whether it was the poll or me or combination of the two, probably. So apologies anyway, please accept my apologies. Okay, so shall we move on then now to the questions? So we've sort of grouped them according to symptoms, diagnosis, services and support, the vaccines and so on. So we'll start, the first group of questions is about symptomatology. So I'm going to start by a question to Dr. Heightman. Melissa, this question is for you. And it goes like this. Since getting COVID, I have persistent fatigue, pins and needles, and weakness of arms and legs. Are these common long COVID symptoms? And what are the most common long COVID symptoms, please? Thank you.
Thanks. So from our experience and from published data, it's fatigue and breathlessness are definitely the most common long COVID symptoms, but these other symptoms are also frequently seen. And what we tend to find is with the other symptoms, there's sort of about a fifth of patients report, the other sort of constellation of symptoms. So these would be familiar to us, but what's really important when you have symptoms like this is that you speak about it with your doctor, because there's obviously several other causes of these kind of symptoms. So it would be important not to assume that this was long COVID. First of all, we need to understand whether was it started by a COVID infection, and that doesn't mean you have to have had a positive test, but did it seem likely that you have had a COVID type illness at the start of this? And then we'd evaluate you in the usual way as a doctor would, to make sure that there isn't any other obvious cause, and then think about whether long COVID is the right explanation, and whether we need any tests to look at that further, and how we'd like to help you cope with those symptoms. So it's really important with long COVID that you don't assume that all things are long COVID, but yes, those are familiar symptoms.
Okay, thank you. So we go on to another question for you. So following on really, do you know why long COVID happens, and how long does it last, do you think?
So these are the questions that we're obviously really desperate to answer as clinicians and within the research community as well. So what do we know why long COVID happens? We have some interesting signals, but I would say at this point we definitely don't have any certain answers. In terms of the useful ideas at the moment, we do identify some risk factors for long COVID, which will be familiar to many of you. They relate to gender, with an increased risk in women, and also age, with greatest prevalence in people around middle age, although it's starting to seem more common in slightly younger people also. In the clinic, we see other risk factors play out. So a patient who had previous fatigue syndrome seems to be vulnerable to getting a flare of that kind of illness. And also we see some patients who have a history of hypermobility, which seems to link to some increased risk of some of the long COVID features. So there's those risk factors that are discussed. And then there are the mechanisms that might be causing long COVID. So what is going wrong in the body that might be causing the long COVID symptoms? And here there are a number of sort of compelling theories, but I would say the evidence is still very patchy and limited. So what I'm going to talk about now are really just theories, and we hope to get a bit more certainty about these in the coming months. So, for example, it's possible that there's been an immune reaction to the viral infection, which continues to be active in the body over several months and might act against different parts of the body, different organs of the body. We call that process autoimmunity. So there's some interest in that as a theory. There is an interest in whether the virus has specific effects on the body. So, for example, we know that COVID affects the cells that line blood vessels. And does that, for example, increase the risk of those little blood vessels getting damaged? And does that contribute to some of the symptoms? We call that microvascular injury. And you've probably read about microclots, which I think is a question coming up later.
Yes.
And there's also interest in whether there's abnormalities in the energy producing units of cells, which we call mitochondria. There's some evidence that those also can be vulnerable to COVID infection, and whether that is an effect that's happening in some people. And I think the feeling as clinicians, given that patients with long COVID can be quite different to each other, is that there's probably a number of different mechanisms, and different mechanisms may be at play to different extent in different individuals. How long does long COVID last? So, you know, we know that a large proportion of people see improvement in symptoms between 4 weeks after getting COVID and 12 weeks. And then there are those patients that have symptoms beyond 12 weeks, where we use the term post-COVID syndrome. And of the patients who have that more persistent illness, we do still see recovery in their symptoms with time, but sometimes it's quite slow. So we do have had a lot of patients who've started to recover by 9 months, but we have a small subgroup who are still unwell at a year. I would say even those who are poorly at a year are much better than they were at the beginning. So I think it's important that we think of long COVID as a condition with potential for complete recovery and significant improvement. And we're really very much hoping that this isn't going to be a long-term, lifelong condition. Okay.
Yes, that's very helpful. And I think it's very interesting to reflect on the very diverse nature of the syndrome. And it's good to hear that people do recover over time, because I think it's very scary for people if they feel that they're going to be stuck in this situation for a very long time. So that's I think helpful generally in the discussion. Okay, so we'll give you a rest, Melissa, and move over to Heidi. So it's another related question, I guess. So the question is, I got COVID-19 over 6 months ago and I still don't feel right. How do I know if I have long COVID or something else? Or when should I reach out for help? Perhaps you could give us an idea, Heidi.
Thank you. So as Mel's already talked about, long COVID is diagnosed when somebody has signs and symptoms that have developed after an acute infection and are ongoing for more than 12 weeks. And I think the important thing is that it's not, these signs and symptoms aren't explained by an alternative diagnosis. So long COVID is really a diagnosis of exclusion. So it's really important to make sure that the signs and symptoms that you have aren't related to any other disease or the problem going on. And it is really hard to identify because there are lots of different symptoms that can occur over time. and they can present in some patterns, and sometimes they don't present in patterns. They can fluctuate in intensity, and it makes the diagnosis more complicated. And there is no one single test that we can do to diagnose long COVID. So over time, as healthcare professionals, we are becoming much more aware of the signs and symptoms of long COVID, and picking those up in general practice, and obviously workshops and webinars like this are helping increase the awareness in the general public. So you know, we're looking out for these symptoms. There are a number of tests that we should be looking at doing in the first place to think about ruling out some of the common causes of some of the common symptoms like fatigue. So we might do things like a blood test to look at people's thyroid function, or to look for evidence of anemia, and just to make sure that there's no other causes, and like I said, for these different signs and symptoms. And sometimes this might mean going for further investigations into the hospital, and for further tests. So the GP might refer on for that. And in terms of when to reach out for help, I guess being aware of the signs and symptoms, and particularly if they're affecting your physical, mental and emotional well-being. And by that, I mean, long COVID has such a range of signs and symptoms. It affects every bit of us, and reaching out for help if those signs and symptoms aren't getting better or are getting worse over time, bearing in mind that they can be fluctuating. And also if they're having a particularly significant impact on what you can do on a day-to-day basis around your activities of daily living, like washing, bathing, and things like having an effect on not being able to get back to work or studying. So if they're having an impact on your day-to-day life and they're not getting better or getting worse, then that definitely you should be reaching out for help.
Thank you. So I think I'm hearing that it's important to get your symptoms assessed. And I'm also seeing in the chat box that quite a few people are saying that they've been unwell for longer than a year. Some people 18 months or 20 months, or since the start of the pandemic, having seemed to get better quite quickly initially. So I guess what I'm thinking, listening, is that it's important to get yourself checked out. Perhaps not every week, but you know, you need to be sure that it isn't something else. And you also need, if it is long COVID, to be getting support and to be getting checked fairly regularly. And I will come on to Stuart, I'm sure, can give some comments in a minute about how DPs can support people to get the appropriate investigations and to understand what's going on with them. And I know that that general practices will be doing what they can for that. And the more we talk about the condition, the more aware everyone is. And so the more likely you're going to get a good response from any clinician that you approach. So I think we could go back to Melissa. And I think it's related in a way to understanding how your symptoms fit with other things you might have, or understanding what's long COVID and what's something else. So the question is, does long-term COVID intensify existing disorders? For example, somebody mentioned that they feel as though their fibromyalgia symptoms are more intense. I wonder if you could comment, Melissa, on that, please.
Yeah, sure. And just to respond to the chat, of course, yeah, we have an important proportion of our patients who we've been looking after really since April 2020. So absolutely, I understand that this is a very long-lasting illness for some people. One of the problems is that we don't hear from the patient voice of the people who have recovered, because they don't come to forums like this. And it's just important to note that there are also people who do fully recover, because that speaks to the potential for recovery. So definitely not trying to say that people who are not still unwell are not really struggling. I experience that every day in the hospital. So, and then does it intensify existing disorders? Very much so. This is something we see an awful lot of in the clinic. So, you know, any pre-existing long-term condition can seem to become more difficult in somebody who's also experiencing long COVID. And we're not sure really whether that's because of the general impact of long COVID on their health, you know, in terms of stress, quality of sleep, fitness, and whether that's you know, having sort of knock-on effects on their other conditions, or whether it's because of the actual mechanisms of long COVID itself. But yes, certainly fibromyalgia symptoms can get more difficult. Pain symptoms can be more difficult. Migraine can become harder to manage. Diabetes control, patients with asthma. So any pre-existing condition can get worse. Sorry for the family background noise here. I've got my headphones on, so I'm fine. Thank you.
Okay, thanks very much. So could we move on to Stuart? Because I think the question we have for you, Stuart, is do long COVID symptoms change over time? Somebody mentioning that after 18 months they have headaches rather than fatigue. But perhaps you could speak to what's coming up in the chat as well about this longevity question.
Thanks, and I think there are, yeah, I mean, I did want to address the 20 months plus symptoms, which I'm really sorry, because it must be incredibly disabling and difficult. And I think probably I do hear a lot of accounts of patients not necessarily being listened to. Certainly a lot of studies looking at people with long COVID, that kind of, there is quite a big barrier to some clinicians taking things seriously, fobbing off, not legitimizing the symptoms. And I think I mean, this is not answering necessarily that question, but I think it'll be something in the diagnosis later. I think if you look at the way medical school and sort of the idea of medicine has been developed, it's been very hospital based, it's been very disease specific over the centuries, really, at least Western medicine. And sometimes that means if the doctor can't do a test and find something, that they almost don't believe that the patient has the symptoms. There's no, obvious kind of walking stick or broken bone or so on. I think it's very hard for the patients sometimes, for some clinicians, to be taken seriously. So I think I'd like to try to, as a clinical lead across in general practice, which is a sort of gateway to the referral service and to get recovery and to get services, we do need to increase the uptake and understanding of GPs and practices of long COVID as a definite phenomenon. We don't understand everything yet, but we do want to get people help where they've got symptoms. And you've got to be believed to have the symptoms. Absolutely, we need to rule out other problems, and there's lots of tests that we can go through a bit later on if you want to talk about those. The actual question was about long COVID symptoms changing. Yes, I think we do see, as Mel said, quite a lot of people do recover, and they're not necessarily going to be at some of the forums where, unfortunately, people here have very long-term symptoms. I think you'll probably find that as we get more research about the condition, that we will be able to help manage some of the conditions better. I think sometimes things like chronic pain, headache can be really difficult to manage even before COVID. So a lot of people were getting these different syndromes before COVID occurred, of course, but certainly long COVID has brought in a lot of these constellations, plus a few other new ones as well. So, if you look at our population as a whole, a lot of people do improve, but I think my advice for helping manage it is to continue to get a trusted continuity of care, usually from a GP, if you've got one that you can access and trust. And I think probably the colleagues in the community rehab and so on can't necessarily hold on to people forever, but can also advise, especially about the breathing and the chest pain and all those other symptoms which tend to happen earlier on in the disease, but can be prolonged. So yeah, my advice was to try to get continuity of care with your GP. I know it's not necessarily that easy for every practice. Perhaps we can talk about some of those, about how to access them, because they're later on in the questions. Okay,
thanks very much, Stuart. And Heidi, how are providers treating patients if they're all different? So it's such a wide spectrum of problems. And are there shared symptoms or treatments across all patients, or is it very much on an individual basis?
So Mel already alluded to the fact that we think that there's a range of potential syndromes and potentially a range of different mechanisms when we're looking at people with long COVID. Some people might have been on intensive care for a long time and might have deconditioning and some of the effects of being ventilated for a long time. Some people might have ongoing lung and heart damage and changes. Some people never got to hospital and were managed in community and might have might have post-viral type fatigue syndromes. And some people might have a combination of some or all of those. So there are some patterns of symptoms that we're seeing together, and it is important to try and track and understand those over time, and that might help us understand a little bit more about what types of therapy are going to be of benefit in the different people. And in addition to that, every person experiences their own signs and symptoms in their own way, based on their previous experiences and their environment. So we can't create treatments where one glove fits all. We do have to maintain a personalised assessment and plan. We are using a set of standardised tools. So some of you on the call might have been assessed already, and you might have been asked to fill in certain questionnaires about your fatigue and your breathing. And that helps us get a little bit more of an understanding about the impact and severity of people's symptoms. And all of us are trained to assess the person as an individual and make decisions on an individual basis about what tests and investigations might be appropriate. Not every single person will have every single test that's available because there isn't necessarily a need for that. So it's really important that we assess the individual and make sure that we're not putting people forward for tests that aren't needed, but making sure we put those forward put people forward who do need certain tests. In terms of where people are being seen, patients who have been in hospital are being followed up by the hospital they were seen at. If people have been managed out of hospital and in the community, then the GP is likely to be their first port of call, and reaching out to the GP practice is really important. And then there is, across the North Central London patch, Mel's team at UCLH, they provide a specialist post-COVID assessment clinic, which is multidisciplinary. There's therapists, doctors, psychologists, lots of people who are able to undertake a whole person assessment and look at what care is needed going forward. In terms of the actual treatment of long COVID, there's different ways that different pathways are being used. And for instance, in Camden, we, as the community therapy team, will go and see people in their own homes. If people are really struggling, we might bring people into a clinic type scenario so that we can see them in the hospital the community hospital where I'm based. We're using telephone and video consultations so that if we don't need to see somebody face to face, we can deliver information that way and support. And we're also using an app that's been designed specifically to help support people with long COVID. And it's got a range of different functionalities, including lots of patient information and treatment management plans around things like breathlessness and fatigue. So there's a real range of things that are being delivered from a treatment point of view. Sorry. And generally treatment isn't just focused on one symptom. Lots of the symptoms interact. So when we're actually treating somebody, we're actually treating the whole person and probably lots of different symptoms at once. I'll be quiet now.
No, it's fine. I'm just thinking, we got some further questions and some of them are sort of overlapping. So I'm just trying to think about how we can best amalgamate some of the questions for people to get the best answers and the most clarity. So our next batch of questions is on diagnosis, some of which we've kind of covered already. But I'm going to ask Wikum. I'm going to bring Wikum in because he hasn't had a chance yet. So there are a couple of questions. Perhaps you could take together. One I was going to ask to Kirsten. So, how long is it on average between someone recovering from COVID-19 and then being diagnosed with long COVID? And who do you think it is who's getting long COVID, and what risk factors do you think there are? Melissa touched on it a little earlier, but I don't know, Wikum, if you have anything further to add on that.
Yeah, so I'll take the first question on length of time to diagnosis. So I don't know what the average is, and for some people it might take time to go through that assessment and diagnostic process that that Mel and Heidi outlined, to rule out other potential causes. I think it might be helpful to just go over the way that the NHS sort of classifies a long COVID. So symptoms up to 4 weeks is regarded as acute COVID-19. Between 4 weeks and 12 weeks, it's termed in the NHS ongoing symptomatic COVID. And a number of people, their symptoms might resolve in that period as well. And then 12 weeks plus is what's called post-COVID syndrome, or PCS. And that's the formal diagnosis that is most commonly used in GP records. But what I would say is, as Heidi and Stuart and Mel have already said, if you're suffering from symptoms and if it's having an impact on your daily life, on your well-being, to get checked out and start that assessment and diagnostic process, because that in itself might take some time, but to not suffer in silence.
Yes, I think that's really helpful. Sorry, carry on.
And then just to your second question on who is getting long COVID. So from the data, both from the estimates that we've seen from surveys and the data we're getting on recorded diagnosis and referrals, it does seem to affect women more than men, and also adults, particularly of working age. So between age 30 and age 70, that's where we're seeing the most cases. But it can affect all age groups, and it does, of course, affect men as well. And also anything that increases someone's risk of catching COVID will also sort of, as a result, increase their risk of getting long COVID. So people are more at risk of COVID and having symptoms that continue are people who are have pre-existing health conditions, people who are overweight, people who are working in occupations that put them more at risk of catching COVID in the first place. So people more in frontline occupations, and also we also see a relationship with deprivation. So people from more deprived areas having being more at risk of long COVID as well. We're not, from the data, it's not clear at the moment if certain ethnicities are more at risk of long COVID than others.
Okay, thanks very much, Wikum. Dan, can I bring you in? Because we are saying we need to go to the GP, and we know that GPs are working extremely hard, but we also know that people find it difficult to access their GP. And if you could just comment a little bit on that from your position in Director of Integration, and also perhaps a little bit more on how patients are assessed and diagnosed, because I think for some people, I'm seeing in the chat that some people who can't get a definitive diagnosis are having problems with their employers. So I don't know if you could just enlarge on that. Rather a lot of questions in there, but sorry about that.
No problem. Happy to try and address some of those. I might start with the point about accessing GP and maybe bring Stuart in on this. But we know that primary care in North Central London is busier than it's ever been at the moment. That there is a very high level of demand on general practice, and we are working really hard to try and make sure that we have got the right capacity there. We've been developing this long COVID pathway, working across all of our providers, all of the different parts of the NHS across North Central London. And I think it's really been great how that pathway has been working together, how we've been able to work across community primary care and the other parts of the trusts and the hospitals to work on this together. But we do know we've got more to do. There was a question in here about how do we make sure that that people are getting the right response from primary care. And one of the things that Stuart mentioned was a GP lead. So we have appointed clinical leads in each area to engage with the primary care body, because this is for many people the first point of call. We've been running a lot of webinars and working with our GPs in North Central London to make sure they understand more about long COVID and that engagement is getting through. But with a new condition, with a newly emerging condition, we know that we need to keep pushing those messages as we learn more and as the research tells us more about it. I might just see if I could bring in Stuart to talk about accessing primary care, because I know there's a lot going on in that area, and he might be able to tell us a bit more perhaps about some of the work in Camden. Yes. But I would reflect on the pressure on the primary care is under, but there might be some specific things.
Yes, please do. And Stuart, perhaps you could comment on people who were never tested positive, because I think that's a real issue for many people, especially people who are at the far end of their long COVID. It was before testing was widely available, and how that impacts on the whole process.
Absolutely, yeah, no. So as you say, in the first wave in February and March and April, we were dealing with, in general practice, we were dealing with people, often people didn't call the GP in the first wave. They kind of got on with it unless they were so sick that they went to hospital when they could do the testing, either the immediate one in A&E or later on with a swab in the acute wards. And there are other clues, obviously, about kind of COVID. This COVID pneumonitis is not something that's the inflammation of the lungs. Wasn't seen, was it, before December 2019, and that was in China. Whatever. I think this is the illness is interesting from a purely sort of scientific point of view. But we weren't seeing that, and then many people, as I say, didn't access in the first wave. And yes, May felt, and there's lots of people saying, I was ill in November 2019, and there's some reports on there in France of some swabs being positive then. So it is a bit murky. I think what I tend to do is to try and take a clear history, a clear, sensible account from the person or their carer about how the patient was. And usually, as Mel says, at least the first strain before different mutations tended to have quite similar symptoms of the lack of sense of smell and taste and fever, and then cough, sore throat, muscle aches, fatigue, headaches in different proportions. But everyone was different, and quite a few people were asymptomatic. And as somebody pointed out in the chat, he might have just had a mild illness, but actually then get quite significant prolonged symptoms, and that doesn't mean that the virus has damaged the lungs or other organs. It's actually, there seems to probably be some immune ongoing changes, which we don't understand. I think the positive thing is this is being incredibly well researched across the globe. If you look at the amount of technology and research that's gone into things like vaccines, which we'll talk about later, it's really helpful and important. So I'm actually quite pleased to be part of this because I think it could be a sea change for management of my patients who, before COVID, I had a lot of patients with a lot of long-term symptoms which medicine couldn't solve, and I'm hoping we'll get some silver lining out of these giant clouds of COVID. Back to how do you get referred? Yeah, as Dan said, primary care is pretty busy. We're dealing with a bit of a backlog, sometimes from the hospitals who've been very busy dealing with COVID patients. I know it's less of a problem at the moment, but there still is quite a lot of COVID patients and it's creeping up. They're having to deal with the backlog of all these urgent referrals and so on. And they're struggling. The staff are ill quite often. There's quite a high level of sickness in the hospitals. So so some patients find that if they're calling a GP, they might be ringing them 8 o'clock, they might be 50th in the queue. And if they don't have urgent symptoms, then, they might say, well, can you call back tomorrow? And then this sort of thing repeats all week, and then they get a few weeks later and they haven't, they've still got the symptoms ongoing. It's not dangerous at the time, but they're very symptomatic. There are other routes that North Central London, in fact, NHS England wanted us to take forward. And actually, if you look at the advice from NHS England before COVID, was things like electronic consultations and accessing through sort of remote. They were quite keen on that. And if you remember, GP at Hand is one that you kind of primarily do all of your consultations through video consultation. So people who are able to, there's the e-consult, which we're contracted to reply to within a couple of days. And I certainly found for relatives, when I've had to try to access care for them and they haven't been able to get through, that's been helpful. I am a little bit more tech savvy than some other people, so I know it's not for everyone. Emails, even letters practices should reply to, even if your symptoms are not acute, that is kind of sudden and worrying. So I think all of those things are ways of kind of improving access. Of course, you can complain as well. It's not what most people want to do, but if with write to the practice manager, and then if that doesn't help, then access to NHS England, I think, is the next step.
Okay, Stuart. So if people come to the GP and they've got long COVID symptoms, you are able to refer them to Melissa's clinic, and you will make a clinical judgment in consultation as a shared decision. Yeah. To get referral to Melissa's clinic. Okay. So
there's a bit more actually. We're required. I'll be very brief, but we're required, really, if possible, to do a set of. It's only as both Heidi and Mel have said, we really want to rule out other problems or causes. Yep. We don't want to refer to long COVID clinic, which might have a long wait if actually somebody's got a problem with their blood. So and we, they've got an issue there. So we want to do the blood tests. We want to do a clinical examination. We want to do a specific test which we don't normally do, which is a sit to stand test. We also provide them with a questionnaire that then looks at the fatigue and their mental health alongside what they want to get out of the referral. So all of that should be then gathered together by the GP, and then it's sent in the different boroughs to the provider. And sometimes that can be Mel's team at UCLH. If they're, for instance, I've recently referred a lady who her oxygen level drops as soon as she does sitting and standing for a minute. So her oxygen levels dropped in front of my eyes, and she's gone to the UCH clinic. Whereas some of the other patients who maybe got longer term symptoms, we try and manage with this multidisciplinary approach, and often Heidi and colleagues will take on for fatigue, for breathlessness, and so on. But there is also other things that we can do to work with patients and work with our GPs. And we can advise the GPs who come to this meeting and say, how can we help this patient? What's the best way? Because they may have mental health problems before, or there could be drug and alcohol or other long-term conditions that are there. So,
so you're able to work then with community-based teams and hospital teams to provide a sort of holistic, integrated system of care. And we hope that works for people. And obviously with the clinical leads, and the more clinical leads you're going to have, and the better organised it gets, and the more people we're looking after in this way, and the more sophisticated it's going to get as time goes on. And we moved back to Melissa, and can I ask you, do you have, are you very overrun with patients, and how long do you tend to keep people in the system with you, and what happens to the people who you have to discharge, and can they still access, well, I mean, I suppose it's a difficult question. If you're discharged from you, what happens if some new approach comes in? How can people slot back in?
Yeah, sure. So in terms of capacity issues, so the number of patients we need to see, obviously we started off with a tremendously difficult situation because literally thousands of patients developed illness at similar moments in time due to the waves of the pandemic. And even with trying to redeploy as much resource as possible, we're able to deliver 120 appointments a week, which is bigger than many other post-COVID services. But you can still see there's a huge discrepancy between several thousands of people needing help at the same time and 120 appointments a week. So we've started off with a challenging situation, and I think we just have to be honest about that. This has been a global crisis. We have done everything we can to try and keep the capacity as big as possible. And at the moment, the wait for clinic is 10 weeks, which is a big improvement on how it was a few months ago. We're obviously really worried about imminent more waves, because every wave generates more people who need help. So capacity remains an ongoing massive risk. And we really know that long waiting times do nobody any favours, because patients need the right assessment and the right advice as quickly as possible. So completely understand how frustrating that is on the other end, being a patient. And then the other part of your question was about if patients are discharged and how they access help again. And I think we were sort of commissioned initially as assessment services. We've always been assessment and treatment services. So we have a cohort of patients who have had probably 10, 12 appointments in our clinic and still are under follow-up because there are issues that we just can't get quite to grips with in a satisfactory way. We have tried to develop a model where we pass patients on to support closer to their home, because for some patients, UCLH is a long journey and they're already struggling with fatigue, and we have capacity problems as well. In our own organisation's case, you are able to contact us for advice for at least up to 6 months after your appointment through the patient portal. So we try to sign everybody up to the patient portal and they can message us. We have a nurse navigator who helps field those questions and escalates them to a doctor when needed. And I know it's not perfect, but it's an attempt to try and give patients some access to further advice. And we would be delighted to involve people in research, and we have a study just about to start up called Stimulate ICP, in which we will be contacting every patient who's been seen in our clinic to get an update of their progress and to ask if they'd be interested in being included in long COVID research. So I hope that there'll be some enthusiasm for that, because the cohort of patients who we've seen are a really important opportunity for us to understand what happens to long COVID with time. And ideally, we would have followed them all up regularly, and that's just been difficult because of the numbers of patients involved.
Okay, well, we'd be very happy at Healthwatch to advertise that research on our website if you want to provide us with the details of what people need to do to get involved. Thank you. So just back to Heidi for a moment. So if people are having to wait 10 weeks, obviously they're going to have a lot of self-management issues. There's also a lot of doubt about graded exercise and what sort of approach people should take to that, whether that is always useful or whether it could make people feel worse. And I know that's a difficult area, but I wonder if you could just say a few words about what people can do to make their lives easier while in between appointments, if you like, while they're managing at home, which is essentially what we all have to do with a chronic condition.
So I think just to reiterate back that if people have had ongoing symptoms and they haven't had an assessment or been to their GP, that again, I would reiterate that's really important to reach out for help and make sure that everything is okay from an other condition point of view. And if that's all been done, and like you'll say, maybe waiting between appointments, we know that everybody is different in terms of how they experience the symptoms. And it is really important to have a personalised approach to both the physical, mental and emotional sort of health and well-being aspects of getting a good recovery. Understanding how to return to physical activity and manage daily tasks without exacerbating symptoms is really important. And to be honest, most of the time I'm saying to people to slow down, to find a platform or an envelope of stability so that they don't exacerbate their symptoms by doing a level of physical activity, and then they can gradually increase over time. And it might be that if people are really struggling, that this needs to be done in collaboration with a therapist and a rehab team to help them do that. And anecdotally, after the first wave, and we didn't know much about the recovery, and long COVID wasn't a thing, we saw lots of people that did push through the symptoms and then did crash after a period of time. And so you're right in terms of the approach to graded exercise. I think we're just very cautious that that isn't necessarily the right treatment and management for everybody. Although I have talked about some people that might have been hospitalised and might be deconditioned and or unfit, and they might benefit from an exercise-based approach to recovering their fitness. So actually, it's not so straightforward.
No, indeed.
Do you want me to touch on a few different self-management strategies, or do you want to do that as a separate question?
I think just briefly, and then we can move on to people who find it, ethnic minorities who find it maybe difficult to access services. So yes, if you could just give us a couple of examples, or maybe if there isn't time, we could you could give us some examples that we could post on our website afterwards. I think that might be the best, if we could, a couple of paragraphs of things that might be helpful for people that they can take away from the meeting.
I can definitely do that.
I think that would be the most useful, actually.
Okay.
Yeah, that's really helpful. Thank you. So Dan, I wonder if you could give us some reassurance that we are reaching all the communities that that are likely to be suffering in this area, that people perhaps who find it more difficult not only to access GPs, but generally to present themselves and to complain about what life is throwing at them. So how can you help us to ensure that residents from ethnic minorities are able to access the long COVID services?
Yeah, thanks. I mean, I think we really don't underestimate the challenge of the engagement piece that we've got to do around long COVID. This is both in terms of, our clinicians and our patients and society at large, possibly. I mean, there is a really big comms and engagement piece that we need to do. I think when thinking about making sure that all residents of North Central London have got access to the right services, then one of our key tools in this is data. And we're dealing with, we think, thousands of people across North Central London who we expect to have long COVID. We know how many have been diagnosed in their practices with the condition. And we mapped that very closely. I mean, Wickam's probably got a better answer for some of the detail on this than I have, but we mapped that very closely against what we call the expected prevalence and the diagnosed prevalence. So where we expect the numbers of patients to be and diagnosis to be made, and where those diagnosis numbers are, we then take that and depending on the gaps and on the gaps, we have different strategies to try and address that. It may be that we talk to a practice, talk to a GP and check that the referrals are working and they understand how to refer. It may be that we want to do a dedicated piece of work, as we've launched in Haringey and Enfield with a couple of populations where we've identified some larger than expected gaps in accessing the right level of healthcare, where we work with local voluntary sector organisations and other partners to try and do more focused pieces of engagement to say to people, look, how can we make this pathway work better for you? So we've got a range of tools that we use to try and address this. We've got a lot more to do in this area. I think we want to use events like this and to work really closely with Healthwatch and with our clinical body to keep pushing the message out there. And I think we're really lucky that we've got a helpful relationship with Healthwatch to help us put on events like this. And we're really pleased you've given us the slot. And I think it's great that we've got the some of the clinicians who are so knowledgeable about long COVID, and indeed some of the nationally appointed people such as Mel, who are leading this across England. So we know there's a lot more to do. We'd welcome specific ideas people have about how we can do this better, but we start with the data, and we start with trying to understand how many people we've diagnosed, what sort of treatment they're getting, and how that maps to our expected population.
Thank you very much. I mean, Mel did give us an idea of how many patients are waiting and how long the waiting is. But Wikum, do you have a figure for to add to that about what the prevalence is in Camden and in other boroughs? Is there anything you can add?
Yeah, yes. So I think the best source for this is there's a very big national survey that's done by the Office for National Statistics that is trying to be representative of the entire population, and their latest estimate for long COVID cases in London is 1.2% of the population. And so if we apply that to the Camden population, that works out to 3,300 cases. And as Mel and Dan have said, that's very different. That's on a different scale to the actual numbers we're seeing in diagnosis and being referred. But so there is a gap there. I think there is an issue with the national survey in that it covers such a wide spectrum of severity, and that it's not clear what proportion of those 3,300 would benefit from services and support. And that number compares to 2,900 in Islington, 3,250 in Haringey, 4,000 in Enfield, and 4,800 in Barnet. So those are massive numbers compared to
huge. Yes.
what the system has capacity to actually support. So that's why it's really we're also really trying to understand what are people's experiences and needs around long COVID and their ability to access services and so on.
Thank you. That's really helpful and very enlightening as to how many people there are. Can we go back to you, Mel? And can I just ask about treatments? And also perhaps if you could say a little bit about the blood clot, the microclots. Just a little bit, because I think there's some concern about that.
So treatments is a big question. So under the sort of umbrella term of long COVID, we recognise that a number of what we are calling now treatable traits. So aspects of the illness that we have been able to develop a management plan for Now, most often that will involve therapy supported by teams such as Heidi, and occasionally there's a role for certain medicines, but of course also a need to actually collect decent evidence on whether those medicines are actually useful. We use a number of repurposed medicines, you know, from experience in managing similar scenarios. But we would say that the therapy approach is a sort of the core of treatment, and often need to be partnered with psychological support, because this is quite a difficult illness to cope with, and that can actually improve a patient's ability to adopt the strategies that are helpful if we give them the right psychological support. It's probably going to take me too long to talk about all the different little components and how we might treat them, you know, but ranging from headache to pain to joint symptoms to disordered breathing pattern. But we do have improving strategies. I'm sorry, my son's decided to sing now in the lounge.
That's all right, I like it.
And then microclots, that's a really tricky one. So this interesting paper has come out where they've looked at still relatively small numbers of patients, because I think it's less than 20 in each group, and found evidence of these kind of resistant protein amyloid containing, let's call them clots, but they're not typical clots. So they're not clots as we usually think of with bundles of platelets, like you would imagine, say you had a scab on the inside. That's not a very good explanation, but I think you can imagine what a normal blood clot is like. These are not normal blood clots that they found in these patients. So amyloid is where proteins form into sort of long strings and become quite resistant. And generally in medicine, we see them in situations where there's ongoing inflammation for years and years. So I would say, first of all, the findings are unexpected, and that's always a bit of a concern with new evidence. And I think we really need more validation of this. So, for example, our haematologists are not swept away by this hypothesis and think that it's all a little bit odd. The paper's published in a diabetes journal, you know, so I think it's really interesting that they found this. It absolutely needs more investigation. We're also interested in clotting and platelets, which are the little tiny fragments that form clots. They do seem to behave abnormally in some patients with long COVID, but not all. And in the study I mentioned, we're actually keen to evaluate a medicine called rivaroxaban, which is an anticoagulant, as a potential treatment for long COVID. Now, I think we can predict it will not be a panacea, but we do have some patients where it's led to some benefits, and it's working out which patients is that kind of treatment approach useful in, and why are these amyloid microclots forming? Is that reproducible, or is there something odd about that paper? So I think it's raised a lot of interesting questions.
That's really helpful, and to know that you're on the case and you're thinking about it, I think is really what people need to hear. And so long as that information filters through to GPs on the ground as well as to where we're going with that, I think that's really useful. I think we can move on now to the hot topic of the day, apart from long COVID, which is the vaccination program. And I know that there's a lot of movement with this at the moment. So I think I'm going to ask Wikum to kick off with this. So I think we're all aware that there's been a change in what the recommendations are for the vaccine. But in relation to long COVID, do you think that the boosters are having any effect on the experience of people with long COVID? And if someone currently has long COVID, should they go ahead and carry on with the vaccine program, with the vaccine schedule? Perhaps if you could comment with them on that.
Yeah, sure. So firstly, I think getting the boosters reduces your risk of getting long COVID. So for people who haven't had COVID yet, getting the booster is another reason to reduce your risk of getting long COVID in the future, because it reduces your risk of catching COVID in the first place. It reduces your risk of developing symptoms if you do catch COVID. And there's also evidence recently that having the vaccine also, even if you do develop COVID, it reduces the risk of your symptom duration as well. So that's for people who haven't got had COVID yet. It's important to get your boosters and reduce your risk. For people who have long COVID currently, there's a separate question on what impact does the vaccine have, and there's a study recently done that shows that the vaccines do reduce symptoms slightly in people with established long COVID. So in that study, symptoms reduced by 13% after the first dose of the vaccine, and by a further 9% following the second dose of the vaccine. And from that, you can also assume the boost would also have a mild positive effect. So while it's not going to work in all people, and it might not completely resolve symptoms, but it's something that you can do that it might have a positive impact and reduce symptoms in people with long COVID.
Okay, that's really good. So the basic message is when you're called for your jab, it's likely to be beneficial, whatever your circumstances.
It's going to be beneficial whether you've had COVID, you've not had COVID. Going for your booster is really important, and obviously increasingly so now that we have this new variant as well.
Yes, and there's no reason for people with long COVID symptoms to avoid the jab.
There's absolutely no reason for people to avoid the jab if they've got long COVID. If anything, it's going to help a little. It might help a little bit. It might make no difference, but it's at least giving them some protection. And also now that we have new variants emerging as well,
we don't know.
You know, there's a risk of reinfection as well. So people might have had COVID and think, oh well. I've got natural immunity, but now that we've got new variants, even that natural immunity might not be enough, and you are at risk of getting COVID again. So that's why it's important to be fully vaccinated and get your booster dose.
Thank you. Dan, can I ask you to reiterate how people can access the vaccines?
Yeah, sure. So there's a number of ways people can access vaccines. For the majority of people, they'll be called via their GP practice. You can also book a vaccine online. And if you don't have access to that, then you can dial 119. And that's the national number to get through to the vaccination booking service. So most people will be called, text message or letter. They'll be notified when they're eligible. And the eligibility cohorts are always changing, but I think they've changed again today, possibly. So you will get notified. Otherwise, it's 119 to ring or online.
And are there going to be walk-in clinics in NCL?
Yes, there will. I mean, I don't work on the vaccine program, but yes, there will be more walk-in capacity. I know that previously NCL's run these large-scale vaccination clinics at football stadiums and other locations, and I think we're looking at doing that again shortly because the eligibility is now been expanded that much more. Yes. So we're going to have to be vaccinating a lot more people shortly. So yeah, there will be large-scale events happening.
And people will be able to access their booster shot from 3 months after their second dose.
I think that's what the announcement today was, yes.
Yes. And so people will be called, but there will also be walk-in centres and people will also be able to book online. So there are lots of different ways. And Stuart, could you comment on whether GPs are going to be going out into people's homes with the vaccine for the booster shots, or is that just still in the pipeline?
Yeah, I can comment on that. It's in Camden, it's CNWL. They are on track to vaccinate everyone who needs a booster. I think in the next 3 weeks, something like that. We had a meeting with the lead there. So no, they're all doing home visits. It's a bit more difficult with Pfizer vaccine because it has to be stored at -70, defrosted, and still stored at -20. And as a logistical challenge, it's been a lot harder with the booster. But clearly, most housebound people presumably will be at higher risk. Certainly older people, of course, but then other people who are functionally less well and not able to leave the home. So yeah, no, it's on track in Camden, and they're doing flu jabs as well.
Yes.
At the same time.
And is it safe to have the flu jab and the COVID jab close together or at the same time? Absolutely. Just to reiterate for people, so you don't need to leave a gap between the 2 injections. No,
you'd leave a gap between acute COVID and another COVID vaccine for 28 days. So if you've got the acute illness, but otherwise, no, it's safe to take. You can't take shingles vaccine, which is a live virus. You can't have those within a week. Okay, that's very helpful. That's very clear for people, I think. So onwards and upwards with the vaccine program. So in terms of the future, can we have a little think about and some comments really on where we're going with this? Obviously, the demand is huge. The demand is likely to grow, especially if we do see a further wave between now and Easter. And do you think that the funding will continue to be in place for clinics like Melissa's and for the work that Heidi's doing? Melissa, I don't know if you want to comment.
Yeah, I'll take that one. Sorry, I was trying to put my hands up as well. First of all, also to say in Camden, we're not doing as well as we'd like for flu vaccination rates. So please, everyone who's eligible, please don't forget about your flu jab. We don't want you to get other viruses. And in terms of funding for next year, yes, we've had good news from NHS England that funding for the post-COVID services will be renewed. And that will be up to NHS London to distribute the money to NCL, who will then distribute it in the way that they think will achieve the best benefits for patients. And then were you asking me about how long COVID's going to be around?
I was going to ask you that, but I hadn't got I hadn't got around to asking that, but I was thinking with the numbers, I think certainly for the foreseeable future, it's going to be around if people can be unwell for a year or more, and we are likely to have perhaps another wave of infection, or at least even if we don't get another wave, if we carry on at the rate that the current case rate, it's a lot of people, and it's going to continue to be a lot of people.
It is, and I think we have to be realistic. Long COVID is going to be around as long as COVID is around, and we're not seeing an end to that yet. So following all the precautions to reduce your risk of reinfection, I think remains extremely important, and we're absolutely pro-vaccination within the clinic. Even in some patients who might experience a flare in symptoms, it does seem to be short-lived. If they have a vaccination, and I think the benefits greatly outweigh the disadvantages overall, because we do see significant worse long COVID symptoms in patients who get a reinfection with the actual virus. So very pro-vaccination, but I think you're right. At this point, we can't really predict an end to COVID, can we?
No, not yet.
There is some reassuring data about a reduced risk of long COVID in people who are vaccinated, but it's a moderate reduction, isn't it, Wikum? It's not removing the risk altogether.
Okay, and somebody's asked in the chat if they've had 2 doses of the vaccine and they've had COVID, do they still need the booster? My answer to that would be yes. Everyone should have the booster. It doesn't matter. I think the booster is recommended for everybody over 18. And that for younger people, there are different guidelines and different time gaps. But in terms of the booster shot for everyone over 18, it's strongly recommended by everybody, really, who's working in the field. So I hope that's clear for people. I don't know if anybody wants to comment. Perhaps Wikum, it's one perhaps for you to comment on. People with long COVID can't work, or may not be able to work, or may not be able to work as many hours as they were able to. What is the thinking behind trying to help people with financial support? If there's any thinking.
So I'm not sure if I'm the best person to answer this, but I will. What I will say is I think the principles of the treatment, the principles of managing long COVID will include that a very holistic, person-centered assessment of that individual's needs. How is their long COVID impacting on their life, on their daily life, their work, their schooling, and then trying to come up with a plan with that patient on what accommodations are needed in those settings. I don't know if one of the clinicians on the call wants to kind of support me on that, but and provide more detail. But that's what I would say.
I guess the rehab team, maybe Heidi, is it something people ask, you know, how they're going to manage? It's part of the self-management, if you like, isn't it? Understanding how much you can do and how and who's going to help you with what you can't do and how you're going to manage. And perhaps for people from less privileged backgrounds, it's increasingly important. And the longer the illness goes on, the more important it becomes.
Yes, you're exactly right, Louise. And obviously, what we have seen is a number of people that have long COVID that are of working age. So it is a really important subject. What's been really exciting across North Central London is that there's been a commissioned vocational rehabilitation service that's specifically for long COVID, and that's just very recently got up and running, which is very exciting. And we're looking to use a bit of a tiered approach in terms of how we use that service, because we don't want to overwhelm them, but that is going to have specialised clinicians who have knowledge and skills to help people get back to work. So things like a phased return and give them the support, advice and signposting to where they need to go for things, I guess, like the financial support and so on. But it is a big problem in this population that we've seen so far, and obviously has a big impact on people's emotional and mental well-being, which then has an impact on their recovery.
Yes, and I think brain fog can be a problem for people, can't it, in trying to work out how to navigate everything.
Exactly. So having a specialised team is really exciting, and we're looking forward to being able to work with them and support you know, some of the people that are really struggling going forward.
Stuart, you mentioned social prescribing. Would you like to say something about that?
Yeah, all practices in Camden at least should have access to social prescribers. I'm sorry, some people in the chat have said that they're finding it difficult to access. Often there is the previous Haringey. Yeah, I'm sorry, I don't know about Haringey. Apologies. Certainly in Camden, we have decent ones attached to either the practice or the local group of practices called PCNs, primary care networks. And they're invaluable. Yeah, so I can look into Haringey. It might be Dan might be able to come in with that one. I mean, so as I said earlier, this is not just a medical condition. It is a medical condition, but it's not just, its effects go through holistically, and that's why we have a multidisciplinary team to help manage people, because it isn't just about getting an investigations or cure. That is really important, the investigations, and they're really helpful for patients and to make sure that they're safe to rehabilitate and so on. But you know, at the moment, this is a novel disease, and as some people on the call are saying, it's 20 months of symptoms that, you know, you can't even do a sit to stand test without being, you know, bedbound for weeks. You know, that's a ferocious illness.
Yes. Dan, did you want to add anything about the other boroughs, because we're talking about Camden, but can you comment across the patch?
Yeah, so I can to an extent. I mean, there are social prescribing services available in Haringey. I know that the Bridge House Renewal Trust in Haringey runs some of those services. What I could do is follow up with Anna to give a bit more detail on how to access those. Maybe we can get that distributed after this event, but there certainly are services available in Haringey, and we can help put people in touch with them.
Thank you very much. Well, I think we're coming to the end of our time, and I think what I would like to do really is to thank all the speakers and thank everybody who is working so hard. because this is a new disease, and the more we talk about it, the more we realize how much we don't know, and I think we've done, you know, despite the experiences of people who've been unwell, people who we've lost, and people who are managing the long-term effects, we have come a very long way in a very short time. And I'd like to acknowledge all the work that everybody's been doing, both on the organizational level as well as on the clinical level. And I think it must be very, very hard work to be dealing not only with the constant changes in the advice at the organizational level and delivering an ever accelerating vaccine program, but also to be dealing clinically with people who are coming to you with a disease that we're only beginning to understand, and to try to provide concrete help and support. So I think we should all acknowledge that we're all in this together. Just because we're on the organizational clinical side doesn't mean we can't be affected, but we can be in a long COVID situation or become unwell just as easy as anyone else. So I think it is very much a thing that we have to face all together. And I think it's been a very helpful discussion to really air some of the issues that there are. And thank you to everybody who has commented in the chat. We've tried to incorporate most of the bigger issues that came up, but it's been very useful. So I think I don't know if any of the speakers feel there's anything else they would like to say that they haven't had time to say. Does anybody have anything they want to add? No? Time for tea. Yes, Melissa.
I was just going to say it's really moving for us as clinicians when we come into direct contact with patients in this way. It's different to being with you in clinic. So thank you for being open with us. We hear the challenge. We are trying to meet it. Don't doubt our commitment.
No, I think that's an important thing to hear and to say and to understand. And I really, really appreciate your time, because you're all very busy people. This is obviously very much part of what you do, but even so, it's an evening and there's kids running around, and it's difficult for people to give up their time. So thank you very, very much, all of you. And in terms of, as I said at the start, the recording of this will be available on the Healthwatch website in the next couple of days. We will have a transcript also of what has been said, and we will try and add some resources, as we mentioned, and anything else that people want to send us, any of the speakers want to send us that they think might be useful. There's been a few links put in the chat box, the link to the research, the link to some of the other services. So we will put as much information as we can on our website. And if anybody in the audience feels that their question hasn't been fully covered, please do email us and we'll try to answer it, or any other things that come up. And as Healthwatch, we're here for the whole population, for the whole of Camden. And we're working with the other boroughs across NCL on a long COVID survey. And we hope to have the results of that before long. You still have time to fill in the long COVID survey if you would like to, so please do. So I think with that, unless there's anything else that we should address, I think we'll call the meeting to an end. And thank you very much to everyone for joining. Bye-bye.